All right, so good afternoon, everybody. I think we all recognize the importance of improving workflows and data integration between our EMRs and the VQI. So we've got 4 exciting presentations showing that we're actually making good progress in these areas. Leading us off will be Dr. Sheila Coogan, who's Professor of Surgery at UT Health and the Regional Medical Director for Sovanet. She's going to be presenting her institution's work entitled Quarterly Long-Term Follow-Up Notifications and VQI Long-Term Follow-Up Epic Templates Improve Overall Long-Term Follow-Up in VQI. Dr. Coogan.
Okay, thanks, Sheila. I guess the big button that says forward will move my slides forward. Is that how that works?
Buttons.
Yeah, I got it. Okay, so it's kind of interesting. This is also a poster presentation, and I just want to go through some of the things that we all know and have been highlighted in this talk. But, you know, VQI is really data collection, and it captures details of the procedure and hospitalization, and it's really good for ideal 30-day outcomes. We have an interesting situation that our hospital is affiliated with our university, but our university is largely separate, and we work in a 12-hospital network. We have about 6 or 7 different specialties, and we collect based on procedure. So when our data abstractors are trying to collect data, it is a very, very wide group of people they're collecting from, and it's at multiple hospitals. You know, long-term follow-up is a very, very important metric in VQI, and it captures data from 9 to 21 months. So this is not a hospital capture. This is all an office-based capture. Remember, the importance of long-term follow-up is that we historically in surgery think of 5-year outcomes. So as we all know, the star rating is heavily weighted towards long-term follow-up because of the importance of long-term follow-up, and it's 40% of the follow-up metrics. So one of our goals in looking at QI projects is how do we improve our VQI score, but also where are the deficits? And the deficits are really in the clinic-based long-term follow-up. So the challenge is that, of course, you know, the long-term follow-up is all clinic-based, and again, it's some private, some academic, different EMRs, and not all unified with the hospital EMR. Basically, one of the main metrics, which I think all of the data abstractors do, is you have to give the hospital or the data abstractors access to the physician's EMR. And remember, we're not one university system, so that became a big challenge. So that happened several years ago, where the physician CMRs were made accessible to the data abstractors. And then in August of 2022, we kind of said, hey, how do we get to this 9 to 21 month metric? Because the hospital knew that we were having these patients come up for review, but the clinics, of course, are completely separate. So our hospital then made a plan to send a notification, and you can find it. I guess there's a tab for all the data managers in here who know this. There's a tab where you can actually see where your patients are coming up for follow-up and their follow-up is due. So what they decided is they would then notify physicians when the patients were coming up for follow-up. My personal preference would they would be able to notify the clinic managers or the lead person in a clinic, but for patient HIPAA reasons and because of hospital's agreements with the physicians, that is not accessible to us currently. But anyway, the physicians would get an email saying you have XYZ patients who are due for follow-up, and then they would then talk to their offices about getting those patients scheduled. So that happened in August of 2022. So then I said, how do we capture all the long-term follow-up measurements? And so we were able to get this long-term follow-up form through VQI. Everybody has access to this. And we basically looked at each of these metrics. And so, you know, one of the key goals is, 1, you have to have a champion in a clinic, and 2, you have to have a way to standardize data collection that's sort of path of least resistance and it's automated. So, you know, I clandestinely called a nurse practitioner who always had great notes, and she's in one office only, but she's the one who likes to build epic templates that are super detailed. And I said, Deb, what do you think we could do? How would we make this work? And thankfully, Deb's, you know, a nurse with like 40 years experience. She's taught at different nursing institutions. She goes, well, I mean, I think what we just have to do is build an epic template. And then, you know, we just had a metric that 6 months from now or something, we're going to have 90% compliance. I was like, well, you know, how would we get that? And she goes, well, I would just build it. And I said, okay, Deb. So really, this presentation is exclusively because of the work of Deb Berry. But I would say if you're lucky, and I was very lucky, I didn't tell Deb she should do it. I just asked, and luckily Deb threw herself on the sword and did this. But she basically built some very, very nice Epic templates, and she worked in conjunction with our Epic support team. And over a course of about a month and a half, she basically created a standardized process. So you gotta make it easy, right? People will do things if it's easy. If it's hard, nobody wants to do it. So this is just an example. This doesn't project very well, but what you can see is Deb created a smart form, and basically when she has a patient come in for follow-up, she basically has a form and it says her initials DLB LTFU. So you click on that and it's accessible to anyone on our system, and basically it has drop-down menus. And so some of these drop-down menus are on the poster, but you can see it has things like, I can't see this, where they live, because I think most people don't think when their patients come back for follow-up, do I ask if they're in a nursing home? But it is one of the things that VQI is trying to track. So it has all of the things that VQI is trying to track, some of which are, I think, more accountable than others in VQI, but has all of the correct metrics according to VQI. And so what we found is if we looked at that particular clinic, from October to December of 2021, there was a 63% capture of data, and between October and December of 2022, after Deb implemented these metrics, it was a 90% capture. So it was effective. I will say the challenge we have is that Deb is in one clinic, but we have 12 hospitals, many more clinics than that, but even within my small group, we probably have 9 UT clinics that all use the same Epic. And although Deb has been very generous in saying anybody can use this smart form, it has not been widely adapted. So there's still challenges we have where we have to get it more broadly implemented and get everybody sort of on board. And I think one of the key things is that if you're really going to be effective in VQI, you need a physician who supports it, but you need a clinic champion, boots on the ground. And I think as a physician and a surgeon, I can say this, and this is my own criticism of myself, but I think it applies to a lot of us, that we have these big ideas, but we always are effective if someone else gets the work done. So, I mean, for all the data managers and all the people who are clinic managers and clinic participants, this wouldn't get captured unless the people in the clinics were willing to support it. Thank you.